Hello and welcome to the Clinical Canvas, stories from seasoned doctors.
This is a podcast series where we share our physician journeys in healthcare. I'm Dr. Seema Pendharkar, a practicing internal medicine physician.
And I'm Dr. Jenny Castillo, a practicing emergency medicine physician. What we share here today are limited to our own opinions and do not reflect those of an employer or any other institutions. So welcome. Today being our episode number 1, our first episode of this series. We'd like to talk about what it means to be an internal medicine physician and like to find out about your journey and pathway of being an internal medicine doctor.
Yeah, so just to go back to the beginning of my career pathway, I did finish a dual residency in internal medicine and pediatrics. And from there, at the time, I thought I wanted to get into academic medicine. So I first joined UCSF as a hospital medicine physician, where I was doing a little bit of teaching, and I was also seeing patients as a hospitalist physician.
So question, when was this? How long ago was this?
So this was back in 2012. That was my first job, and I stayed in that position for probably about 2 years. And
What made you decide to choose internal medicine?
I really love writing. I like reading. I like thinking. So I think that it's really fun to come up with a detailed assessment and plan for medically complicated patients. I really enjoy that.
And was there another option for you in terms of what specialty you would use? I do.
Yeah, in terms of, I did complete a residency in pediatrics as well, and I enjoyed that as well. I thought about subspecializing in infectious diseases because there was a time when I really enjoyed traveling and sort of global health and that sort of thing. But I decided to just kind of go with hospital medicine ultimately.
So instead of doing like a private practice for internal medicine, you decided to focus more hospital? Was that the options?
Yeah, and I had a special interest, in patient safety and quality and research on those topics. And so that was another reason why the academic setting made a lot of sense for me. I was really drawn to that.
Did you know ahead of time what it meant to be an academic medicine,
Yeah.
physician?
Yeah, I think I completed my residency in an academic setting. And so I think in some ways I thought that was probably the only option. I think that I did do some rotations in private practice, but I'd say that in the place where I did my residency, well, which was at Duke, private practice in a way was almost frowned upon. Like it was a little more prestigious to pursue academic positions. So in that sense, I was probably influenced a little bit by my peers and things like that.
Oh, I see. Okay. So you went from Duke to the West Coast?
Yes, to UCS at the West Coast.
And why did you decide to make such a big change?
Well, my sister actually had lived on the West Coast for several years, and I would visit her, and I really thought I could just explore the climate and different setting and that happened.
And so what was kind of like your career journey or your learning within that first, say, 5 years of being an internal medicine physician?
Yeah, I would say that, I really loved the actual clinical medicine, like the patient diagnosis. I loved looking at different studies and research and literature. I did try applying for several grants to head up different quality patient safety projects. And I found all of that really appealing. But I do think that at times it was a little more difficult to sort of break into those areas, if that makes sense. I felt like I had to work really hard to sort of get the acceptance, if that makes sense.
So going into this first job, you had to learn the clinical skills, though, residency, you're learning a lot, but being an attending is kind of taking it to the next level in terms of your clinical skills. So in addition to clinical skills, you were also trying to almost do like a research aspect of it by applying for grants. That's a lot. So how did that all fit together?
Yeah, I would say that, like luckily my residency training, I feel like they gave us a lot of practice independence, so I think that it allowed me to be really secure with my clinical skills. So that the clinical piece and the teaching was something that I don't think I had to worry about too much. I mean, I think every new physician is a little stressed out. So definitely I had that piece going on. I think the hardest thing that I probably had to navigate was the political piece in terms of navigating any hospital system. There's a very, very large political piece that I think probably to this day that I would say I probably haven't mastered that. And it's really not something that I enjoy. And I think that if I had known that that was going to be a really significant component, I probably would have explored private practice a lot earlier.
Oh, okay. What about, was there a huge learning curve in terms of your clinical work, and how did that come about? Did you feel comfortable being an attending, or did you have to adjust some things in order to get to where you wanted to be or felt like I needed to be?
Yeah, I think I would say the hardest part was trying to do sort of the clinical part. And then on top of that, grant writing, joining the right committees, connecting with the right people. And especially since I went to the West Coast on my own without any connections, I had to do all of that sort of from scratch. So networking actually is something that I still really enjoy to this day. And I think even back then, I enjoyed it, but I think building those new connections and relationships, it definitely takes time. So
Did you have any mentoring at that time, or did you kind of not realize that that was as important as it was potentially been?
yeah, actually it's funny that you mentioned that. The strongest mentor that I had actually was somebody who was in health tech IT. So he wasn't a physician, and I actually recently saw him 3 weeks ago when he visited New York, and I'm still in touch with him. But he was definitely very generous with his time and trying to connect me. And I got like a $20,000 grant to build an app and do some interesting things in health IT. I don't think it was as easy for me to find other physicians that were sort of mentoring me. And I would say I like the word sponsoring, actually. I think that's kind of an important distinguishing factor between mentorship versus sponsorship. I think that you have to find a person that really is going to feel like they're investing in you and they want to see you advance and grow, if that makes sense.
As opposed to, what would you say a mentor would be as a
Yeah, I mean, I would say like a mentor is somebody that like maybe you could check in with, you get lunch with. A sponsor, I would say, is somebody that's actively, has your interest in mind, and they're actually maybe even seeking opportunities and things for you when you're not even thinking about it.
So ideally, it would be someone, a mentor and sponsor would be the same person.
Yeah, exactly.
Ideally.
Yeah, yeah.
But, was it hard to find, say, specifically a woman who has already gotten grants and already gotten funding in a academic setting to try to help you along? Or was that even a possibility? Or
Yeah, I mean, I would say that in my experience personally in academic institutions with women mentors, and this is just my personal experience, I know that a lot of women had to like really struggle to get into those higher positions. And so I think that they were harder to come by. That was my experience. I did
harder to approach, or harder, it just that there was fewer of them, or
I think probably fewer of them. They were spread thin, so they probably already had like, groups of people that they were already sponsoring and mentoring. So it was harder. And same.
So how long did you stay on the West Coast then?
I ended up staying for a total of 2 years.
And then after that, where did you go?
At the end of my time in San Francisco, I decided that I wanted to be in New York, and I actually came to New York without a job, without a plan, without anything concrete. I just knew that I wanted to be in New York. And luckily, as a hospitalist, I think generally it's been easy to find locums positions. And so that was sort of my next move, was that I got into locums a little bit.
And so can you describe locums and how that works?
Yeah, yeah. So locums, I'd say, I mean, it's still, you need a good network, you need connections and contacts. And I think at the time, it wasn't something that I knew a lot about. I just kind of put my feet in the water. There were hospitals that had a need for internal medicine doctors. And so I found a few places and I just tried it out. And I didn't really, in terms of navigating contracts and that sort of thing, I didn't know what I was doing. And in terms of the patient care, that always came to me pretty easily, and I enjoyed it.
So how did you figure out the contract part? Like that seems very kind of overwhelming.
Yeah. Yeah. I mean, I would say that probably for a few years, I would say that I probably really did sell myself short, so to speak. And
Tell me more about that. What do you mean by that?
yeah, I mean, so I think that when you're navigating a locums contract, there's a lot of different things that you have to sort of consider, including, like what's the patient load? How many patients are you going to be rounding on? Are you going to go round on patients in the ICU? Are you going to be doing admissions? What's the structure of that hospital? Is there support? And then, of course, the thing that people think about the most is the pay rate. But I would say that that's probably the least of your concerns. I would say the top thing is you want to put yourself in settings where you're not going to get sued. It's safe to do patient care in a high quality way. And I would say that you have to trust your contacts and talk with people to get that information.
How would you know that it'd be safer, like in one hospital as opposed to another?
Yeah, and I think asking a lot of those key questions is really important. Like, how many patients am I going to be rounding on? Do I see ICU patients? And I think that, like, once you get an idea of the structure of a particular hospital, it really gives you an idea, if you're savvy, as to whether that's a place where you're going to be safe.
Safe, so as in like you have backup in case you need help, or if you are just going to be kind of left to be the only doctor for
Yeah.
hospital. Is that what you mean by
Yeah,
safe?
exactly, exactly. And I'll just give a brief example without naming any names, of course. But a recent hospital that I was at, the staffing was, I'd say, very minimal. They had specialists on their roster who would never really come into the hospital when you needed them. They had ICU care that was only done by video visits. And of course, an ICU level patient is somebody that needs to be seen in person by the ICU doctor. So those are the types of hospitals that I would not go to, because you can't keep the patients safe. If my own family was going to a hospital like that, I would take them out right away and send them somewhere where they could have access to the specialists and everything that they needed.
So is that like I would think that it's only a rural area that the hospital would be.
I wish I could say that, but no, that hospital was in, a city that we're currently in right now. So,
Oh wow, so a big
yes.
big city that
Yeah.
that has options.
Yes.
Have people. It's not in a rural,
Absolutely. Yeah.
very rural place.
Yeah.
With Midwest or something.
Yeah, unfortunately. And I mean, I think a lot of hospitals these days are being acquired by large venture capitalist companies. And so, unfortunately, a lot of those organizations are very invested in their profit. And so that's the way that they save money. And so, again, I think that I encourage physicians to be astute and to be savvy, to talk with the people that are already in that hospital. Again, you could be in situations where you could be the best and brightest physician. However, if the safeguards and things are not in place in that hospital, you're setting yourself up for failure.
Wow. So how long did you do locums then?
I've done it on and off actually for I'd say the last several years. I had initially I was more attached to like a W-2 type of setup, because that's what I knew. I was familiar with that. But I think as the years went by, I realized I would have a little more flexibility and a better lifestyle.
So you went from the West Coast to locums in New York, and then did you ever get like decide to work specifically in a place in New York?
Yeah, I did actually go back to a W-2 position, and I was at Mount Sinai for a couple of years where I learned a lot. I was in a leadership role there for hospital medicine. So again, I did learn a lot, and it was an interesting experience.
So how was the leadership role different, or how did you combine that into your clinical work? Like how did that work?
In a lot of these academic institutions, when you do the leadership piece, it's almost like a side note, in the sense that you're still expected to do the patient care, and that responsibility is still there. So I did find over the years that in these clinical leadership positions, oftentimes it didn't feel safe, because, you have to focus on the patients, but then you're being asked to attend a lot of meetings and this and that. And it's a little bit unrealistic, this is what I found.
So did you ever get any like your time amount of clinical work decreased because of your administrative duties?
Yeah, I mean, in a lot of those positions, they will tell you that you're getting, say 60% clinical, 30% admin. But at the end of the day, I found myself in a lot of positions where I was the chief of hospital medicine, and then the rounding doctors, they would get stressed out and they would say, "Oh, I have 25 patients today. Will you take 5 of my patients?" And then you get pressured like that. And even the higher administration will sort of encourage you to just go ahead and keep working, until you feel that, it's just not feasible, and you get frustrated.
So how long did you do that?
So again, I would say that I've never really lasted in a clinical role for more than 2 years in a W-2 position, because like my frustration level would just skyrocket, because again, a lot of those positions, they don't want feedback. They just want to tell you sort of what to do. And again, if you're not up for working around the clock day and night, then a lot of times the only option is to transition into something different.
So what did you transition to from there?
So basically, I think when I'd say I hit sort of rock bottom, in the sense that I realized that, I don't want to work for these types of employers that, are forcing me to do these positions that are unsafe. They're not thinking about my wellness. They don't care about how I feel. And I sort of hit that point, and I started exploring, how could I, still continue to do clinical work in a way that feels safe and comfortable for me. So I'd say that sometime after the pandemic, in 2020/2021, that's when I started exploring the idea of a private practice a little more, and then having locums on the side so I can kind of build up the private practice piece a little more.
And so what is building up a private practice? What does that even look like?
Yeah. I think there's a lot of different versions, actually. And so I think the standard model is having, like, your own clinic where you see the patients, they come to you, they're sort of like your own patients. And that's actually sort of the vision that I had. But then I think somewhere along the way, there were other opportunities that came up for me. And so one aspect of my current practice is that I have sort of like a locums model where I have 3 or 4 physicians that will go and do care in other facilities where they have a demand. And that's not really sort of what I was planning on, but it was like sometimes the opportunities will just come to you.
And so you're doing that, and then in what settings is that hospital settings, or is that like?
So that's a post-acute care facility, so like nursing homes, and sort of sometimes it could be LTAC facilities as well.
So how do you find that difference than, say, hospital medicine?
So I actually never envisioned myself working in that type of a setting, but it's been really rewarding, actually. I think that a lot of the patients, they have, again, they can be medically complex, they have need, and doing basic things like adjusting their medications for diabetes, blood pressure can make a tremendous impact. And even as my own dad ages and I help him, you just realize how much care people need in their over years.
And so do you feel like you are having that longevity that internal medicine physicians like with patients in this setting, or is it you're kind of coming and going?
Actually, it's nice because there is a continuity, and you see some of the same patients and you really get to know them, and you get to know their story. And yeah, it's really fun. I have this particular memory of sitting at a table with some older ladies with dementia, and they had like a robotic cat they were playing with, and their eyes just like sort of like lit up, and they were very grateful that I sat down with them. Sometimes they'll ask you to play bingo or just other games with them, and it's really nice, because sometimes as a hospitalist, you can get pulled into more stressful situations where people are, they're feeling stressed and angry. And so this is a different type of experience.
So how is this different for you personally? Like in your life, your everyday life, how does it work? Is this a better situation for you? Is this
Yeah.
like financially, is it concerning to you? Questions like that.
Yeah, I would say that it's a better fit, because I think when you're managing your own sort of practice, at the end of the day, you get to control your own schedule, So I have a scheduler that helps me. And for example, I've told her that, I don't want to work on these certain days, or these are the limitations. And you can really kind of adhere to that. But then on the other hand, when you're sort of a business owner, I guess, you are working around the clock, and having to do things like accounting, bookkeeping, scheduling. Those are things that I actually do enjoy them, and I've learned how to do them, but it's not something that I was doing when I had a W-2 position.
Right. Yes. I know that entrepreneur part of me is, I don't have it. So I like other people to do that for me.
Yeah,
So, but I can understand that that would be something that would be really empowering as well.
it is. Yeah, it's definitely something I have invested time into in terms of learning from other people that are experts that have taught me and are teaching me. So
So you're like financially fine, like you're living, you're
Yes.
even though you don't have like a set job with 401k and healthcare benefits and all that, you are fine.
Yeah, I mean, I would say that I'm even much better off than I was when I was doing a W-2, because again, this is sort of a situation where you get to control it, right? I mean, I could work 7 days a week, 24/7 around the clock if I wanted to, but I don't want to do that yet. And so it's my choice. And again, you can kind of do it based on what your financial goals are. And I think these days I do try to do more of like a minimalist. I think they call it like low consumption or something like that. I think there's a term for it on social media, but I think it's better to live a simple life, work less. I like that concept.
Got it. And so out of your, how many years have you been in tone lessons?
So I have been practicing for 14 years now.
So for the 14 years of your career, any big take home points, any big, suggestions for someone who might be interested in going into internal medicine?
Yeah.
Well,
Yeah.
what kind of things have you learned that you would like to pass on to others?
Yeah, I would say like the top thing would be don't be discouraged, because I think a lot of times these days we hear about how people are so burned out and they're so miserable in their clinical roles. And I do think that that can definitely happen if you're in the wrong situation, but you can turn your situation around much quicker than you might imagine, And I would say my top tips would be number one, surround yourself with people that are thriving. They're in positions that they're enjoying, because I think at the end of the day, what we do, which is caring for people, helping them with their health, it is like very rewarding, and we don't have to abuse yourself to do that. You really don't have to, even though I think that that's kind of the constant message that we get. Like even in residency, they had a certain mantra, which was the Duke Marines, I think, which meant just put your head down and keep working and working and working. And I don't think that that's really like a healthy mantra.
Excellent. Well, thank you so much for sharing all that information and your journey in internal medicine. And we'll see you next time.
See you next time. Take care.